Hello and welcome to Principles of Exercise Therapy, Lecture 18. This week we're covering cardiac rehabilitation. Cardiac rehabilitation is probably about the most important thing in physiotherapy because the heart is the most important muscle. Why? Because nobody ever died of a weak bicep. Let's focus on physiotherapy, our profession. We are concerned with human anatomy and physiology, human movement and function, maximizing wellness and potential, minimizing disease and injury, and ultimately solving real-world problems. So today's session, we want you to learn how to recall, how to monitor exercise intensity. We want you to apply the principles of exercise therapy to a cardiac rehab environment. We want you to discuss muscle balance within a circuit. This means that you're not just training the same muscle group. For example, lots of variations on a squat, which is effectively, training the same muscle group. And we've got the core components of cardiac rehab. You're going to warm up, you're going to do some conditioning, you're going to do some flexibility, then you're going to cool down. So the principles of exercise therapy are applied as they would be in a group environment to an individual environment. You're talking about adaptation, specificity, progression, regression, overload, reversibility, time out, behavioural change, individuality, lifestyle integration, the law of diminishing returns, and your responsibility. Okay, so what is cardiac rehab? Basically, it's going to be a form of physical training that's medically supervised and is sometimes physio-led, or it might be led by the consultant cardiologist or indeed the exercise physiologist. And it's going to improve the health and well-being of people who have cardiac problems. Cardiac rehab will include exercise training, education on healthy living, and counselling to reduce stress and help patients lead an active life or return to an active life. So the definition: it's a coordinated sum of activities required to influence favourably the underlying cause of cardiovascular disease, as well as to provide the best possible physical, mental and social conditions so that patients may, by their own efforts, preserve or resume optimal functioning in their community and through improved health behaviour, slow or reverse progression of disease. What a great paragraph that is. So, BACPR are the organisation that look after cardiac rehab. We'll come on to their guidelines a little bit later. Okay, but there's lots of people who cardiac rehab refers to. Okay, so we've got angina, we've got atherosclerosis, we've got revascularization, we've got cardiac conditions, stable heart failure, congenital heart disease, okay, heart transplants, whether you've had a valve, whether you've got an ICD fitted, all of that comes in to cardiac rehab. So they're our target population. So the inclusion and re-inclusion to cardiac rehab also applies to the following conditions. So acute coronary syndrome following revascularization, stable heart failure, stable angina following implantation of cardiac defibs and resynchronization devices, heart valve repairs or replacements, and heart transplantation and ventricular assist devices, grown-up congenital heart disease, and any sort of atherosclerotic diseases, peripheral artery disease or transischemic attacks, TIAs. Okay, so cardiac rehab MDT. Normally, it's going to be led by a consultant cardiologist, although not always. Okay, and then there will be a physio, that's you. There will obviously be an exercise physiologist for specialist advice around exercise. Cardiac specialist nurses. There'll be a dietitian, a counsellor, and there'll also probably be an occupational therapist who'll be doing some cognitive behavioural therapy and giving advice about activities of daily living. So there are 7 core components to what we're doing here. The first is health behaviour change and education. Okay, so we've got to, after you've had a heart attack or a heart issue, you realise that your health behaviour needs to change. And in order to do that, you've got to be educated about that. Okay, it's going to be probably a potentially very scary time for that individual, and they're going to want advice and education. Then we've got to manage their risk factors. How much physical activity and exercise are they getting? What's their diet like? Are they still smoking? Okay, so we've got to address these factors as well, because if you don't do any activity, you've got a poor diet and you're a smoker, you're bound to get a heart problem. Okay, and you've got to take responsibility for that as a patient. Okay, you're going to have a look at the psychosocial health stuff, the medical risk factors involved in the management, maybe some cardioprotective therapies, long-term management, and of course audit and evaluation is important. Okay, that we're managing the numbers as well. Remember, what gets measured gets managed. So the benefits of cardiac rehab, and this is really important. Okay, and this is where BACPR have done some fantastic work with the British Heart Foundation. Okay, we can reduce all causes of death by up to 26%. Okay, that's huge. Okay, in terms of cardiac mortality, up to 36% reduction. Okay, reducing morbidity and unplanned admissions by nearly half. Okay, it's also going to improve quality of life and functional capacity. So there are massive reasons to do that. NHS is significantly overburdened, and cardiac rehab is cost effective. And it's going to support early return back to work and development of self-management skills. So it's a 4-phase structure. The first is obviously diagnosis and treatment. Then you'll be discharged. Then you'll be involved in the outpatient rehabilitation program, and then you should get some continued exercise and lifestyle modification. So 4-phase attack. Okay, patient-centered care. So we've got to understand their condition. They're going to be frightened. They're going to want knowledge. They're going to be in a vulnerable position. They'll be recovering from surgery or some sort of procedure, or indeed maybe just a heart attack. That's going to make them reflect significantly on their lifestyle. Okay, and if they want to stay alive, they're going to have to change their behaviour, and we've got to reduce those further risks so that we don't have another heart attack. Okay, so the outcome measures that we might use will be functional exercise capacity. We might do an incremental shuttle walk test, 6-minute walk test. Obviously the metrics of blood pressure and heart rate, part of your vital statistics. We can measure body mass index, which is your weight over your height squared. It gives you a numerical value. And we'll also look at waist to hip ratio. Okay, if your waist is greater than your hips, okay, then we need to be doing something about your central adiposity. Okay, so how are we going to measure effort? We're going to measure effort by taking their heart rate, their pulse. Okay, we're going to also look at their work of breathing. Also, how they look. Are they using their accessory muscles to breathe? We're also going to ask them the rate of perceived exertion. On a scale of 6 to 20, using the Boyle scale, how hard do you think you're working? Okay, and we'll come on to that in a second. And we've talked about monitoring blood pressure both before and after the session. We could also stick the pulse oximeter on them and measure their oxygen saturations, and we could do the simple talk test. Okay, if they're able to talk to you while they're exercising at the right intensity. Okay, so we talked about rate of perceived exertion. You can have it from 0 to 10 or 6 to 20. Okay, and they want to be working around probably about 13 on the Boyle scale, 6 to 20, which is somewhat hard. Okay, we can have a heart rate monitor on. I'd always recommend it, but just remember they're not always reliable, but they're more reliable than taking your pulse on the move. Okay, so your risk stratification. So you're going to be classified according to your medical history: low risk, moderate risk, or high risk. Okay, we're going to work out some training heart rates. So for a maximum heart rate is 220 minus your age, okay, and then we want 60 to 75% of this figure. So if you're 20 years old, 220 minus 20, okay, is 200. 60% of 200 is 120. 75% is of 200 is going to be 150. So we want to be working between 120 and 150 to get our training effect. No higher than 150, but no lower than 120. Okay, and what I want you to do is work out your own target heart rate, your own training heart rate. Okay, go and do that now, and then come back to the lecture in a second. Okay, I'm assuming that you've done that, and we shall move on. Okay, now there is a better method of calculating this if we want to be really specific, and in cardiac rehab, yes we do. And that's the Inbar calculation method for max heart rate. So we've got the normal 220 minus your age, okay, and here we're making an age adjustment, okay, so that we can see where we normally do it, it will give you a score of 200, but using the Inbar calculation, it gives you a score of 192. Okay, this figure is going to be far more accurate, although we won't penalise you for not knowing it. 220 minus your age is the ideal, okay, and the Inbar calculation will be a gold standard. Okay, medication. Basically, if it's a beta blocker, it's going to be an OL, okay, bisoprolol. Okay, if it's a calcium channel blocker, you might have something like this, okay, and if you're going to have any of these two, then you might need to take 30 beats per minute off your calculation. So if you had a max heart rate, okay, of 192, if you're on these meds, okay, that's going to drop it down to 196. You need to be aware of how medication affects heart rate. Okay, so group exercise. We obviously have to make the patient feel welcome in the class. Yeah, you've got to create an environment that gives them a positive experience. Otherwise, they just won't come back. They've got to learn new things. They want to get to know other people. It needs to be a social experience. And it needs to be taught in a safe and effective environment with safe and effective exercises. We don't want people hurting their knees, their backs, their shoulders, whatever. Okay, and they've got to believe that their time, their valuable time, is being well spent, and that's important. Okay, remember that when you're designing an exercise for cardiac rehab, it will probably be in the form of a circuit. So we're just reminding you of the 6 steps of exercise progression. First of all, we're going to isolate and educate a particular muscle group. So it might be just tensing your quads. Can you isolate your quads and just tense them? Okay, and then what you might want to do is add some resistance. Okay, like an ankle weight or something like that as you're doing a leg extension. Okay, and then you want to be adding a functional position into that. So that would be a lunge, a squat, a deadlift, stepping up, anything like that that's functional. Then you want to increase that function by adding some resistance, okay, and then you want to be working in a compound way with multiple muscle groups working from the core to the extremity. So now we're doing a functional task, which is involving the whole body. And then you can add balance, speed, rotational movement, whatever you like, because you've progressed to that level. So the warm-up, okay, you want to take a minimum of 10 minutes, okay, to get those coronary arteries dilated. That's important. Okay, so 10 minutes of gradually warming up, okay, as a minimum. Okay, remember these are just guidelines, but we'd always follow these guidelines because they're just good ideas. They make sense in terms of your clinical reasoning. Going to increase your body temperature, going to increase your blood redistribution to your working muscles, going to increase your oxygen supply, and synovial fluid is going to be increased in the joints, lubricating those joints. Remember that motion is lotion. Okay, conditioning component. You want about 20 minutes minimum of conditioning. Okay, and that could be continuous or in the form of intervals. You want this moderate intensity, 60 to 70% of your heart rate max. That's important because that's overload enough to get you doing the biz. Okay, so you want to consider muscle balance throughout the circuit to prevent overuse, to prevent certain muscles getting stronger than others, so you're just overusing the same muscle groups, and you want to train in a functional pattern. So if you do a push, you need to do a pull. Okay, if you do a squat, you need to do a deadlift. Okay, try and balance that circuit. Don't just repeat the same exercise. So muscle balance. We talked about working both the agonist and the antagonist. We've got to think about the assister or the stabilizer muscles, and exercises need to be functional. Okay, a bicep curl is not functional. Okay, stepping up and stepping down is. Okay, you can also add resistance according to the patient's level, but just make sure those exercises are functional and we've got some functional carryover to activities of daily living. Okay, the cool down. Cool down's massively important. It's going to prevent arrhythmias, and it's also going to prevent hypotension. Okay, that low blood pressure. What we don't want is blood pooling in the legs because of the reduced venous return. Okay, and thus the decreased cardiac output. This rapid drop, we've just got to be careful with. People have had a great exercise session, okay, and their blood pressure drops, okay, and then they feel unwell, or they might feel lightheaded or blackout. So if we cool down for, again, another 10 minutes as well, that gives them a good chance for the heart rate and the stroke volume to normalize as we come back to homeostatic values. Okay, so safety issues. We've got to think about what equipment is available, what safety issues might be involved. Risk stratification and any sort of pre-screening should always be completed well before the class begins. Your PAR-Q, obviously important. Patient notes are massively important. No one does the session unless you know their medical history and they are fit to exercise. So we're now going to cover some behavioural change in the form of the 5 A's. So we've got to facilitate behavioural change in patients in the context of promoting physical activity and exercise. So we've got to assess what's going on with them, maybe assessing the barriers to exercise. Then we're going to give some advice about what they should do in order to live a healthier life. Then we want them to agree with the fact that that's probably a good idea. Then you're going to assist them to help them reach their goals, and then we're going to arrange the next appointment so that you can follow up and make them take responsibility and accountability for their new behavior. So remember that exercise adherence is not always good. You know, we have the wonder drug exercise, but we just can't get people to do it continuously. So cardiac rehab normally lasts 12 weeks, okay, or it might last 6 weeks where you do 2 sessions a week. Whatever you do, okay, it's going to be normally about 12 sessions of cardiac rehab. And we've got to use all those success strategies to increase adherence to exercise. So by the end of this lecture, hopefully you've managed to recall how you monitor exercise intensity in the form of rate of perceived exertion, vital signs. We are applying the principles of group exercise therapy to cardiac rehab. And remember to create that muscle balance within a circuit. Don't just repeat the same exercise. Your patients will get bored in addition. Okay, we've got these core components, the warm-up, the conditioning, the flexibility, and the cool-down. Okay, I've got a load of references there, should you require them. But thanks for listening, and we shall see you in the next podcast.